Dear colleagues and friends, dear attendees of the Romanian Diabetes Association meeting, it's a great honor for me here to talk to you today. And what I would like to do is to highlight the prevention of diabetes, especially prevention of type 2 diabetes. If we are honest, as diabetologists, as diabetes teams, and all the physicians and teams dealing with people with diabetes, the true challenge or the most honest therapy of diabetes is focusing on those at risk and doing whatever we can to prevent diabetes from developing. Let me share my slides and let's discuss this topic together. What is driving me and many colleagues worldwide about prevention of type 2 diabetes? About myself, Peter Schwarz, I'm professor for prevention and care at the University of Dresden. And I apologize for being not personally at your meeting, but a few days ago I had a small surgery, and that's why it's difficult to travel in the moment. What is special about or unique about myself? Over the last 25 years, I was dedicated and I was focusing on aspects of prevention of diabetes. But not only the scientific aspect, I was always driven, how can we do it in practice? How can we implement diabetes prevention into clinical practice, but also public health practice and policy development and so on. Currently, I'm elected as president-elect of the International Diabetes Federation, and for the next 2 years, I'm the president-elect, and then for 2 years, I'm the president of the International Diabetes Federation. And also there, the main focus of my work will be prevention of diabetes. But let's dive into it. The current situation is a challenge, and here you find 540 people from Facebook. All the red ones will develop diabetes through their lifetime. And now you could say, oh, there are many people red. If I would show this slide from, for example, Saudi Arabia, it would be totally red. Saudi has currently a prevalence of diabetes by about 43%, and they expect in 2030 57% prevalence of diabetes. This means more than every second person has diabetes in this country. And if you then know that the age pyramid is totally different than ours in Europe, that 2/3 of the population are below 35 years of age, it shows the dramatic development in some of the countries. And these red dots here represent about the European population, but there's also a lot of hope in this slide, and these are the green ones, because the green ones, they have the same lifestyle, they do the same things wrong, we could say. Yeah? If the green one walks through the door, you say it's a metabolic patient, but they have a perfect insulin sensitivity, they have no diabetes risk. The green ones have something in them, or they do something what leads to sustainable prevention of diabetes. If we would know the secret of the green ones, we would have a very effective intervention to prevent diabetes from developing. There are many research groups working on it, and it's not known yet. For example, the green one could be women taking anti-contraceptive pills, eating tiramisu, and drinking a glass of white wine, because this is a one-way road to accumulate liver fat. And we know liver fat is a booster for diabetes risk, but even those are not getting the diabetes. And this differentiation between both, it's a very interesting, very hot research topic currently. But over the last years, there's a lot of new information about prevention of diabetes. And in my eyes, this is the most easiest prevention information. These two numbers, and if I would be in front of you, I would ask you what you think, what it does it mean. And the first number is, if we would walk 10,000 steps from the age of 22 every day, we would not contract any chronic disease. No diabetes, no metabolic syndrome, no depression, no dementia. This is strong information, and it's actually getting better. If you have diabetes, and it totally doesn't matter how much you are walking per day, if you increase only by 1,000 steps per day, this is walking 600 meter or 700 meter, 1,000 additional steps lower the postprandial blood sugar by 1.5 millimole. This is twice as much as 1,000 milligram of metformin are doing. So this again shows the power of physical activity. if you're honest, the true diabetology is not in our brain as diabetologists, it's not in our prescription as diabetologists, it's in the muscle of our patients if we would be able to activate this muscle. And we know this is often difficult. It's also difficult to activate our own muscle. So if we look at ourselves, we often are not a good example for our patients to this information is very important because it shows us the power of physical activity for our patient. But what is the reality? And if you are looking how many steps we are normally walking per day, it's about 2,500 steps, at least in Germany. And if you translate it into another question, how many hours per day we are physical inactive, the answer will be it's 23 hours and 45 minutes. We are physically inactive per day. And this is part of the problem. But we are physicians, we have to understand the pathophysiology, and the pathophysiology tells us something different since we have the glucose sensors and CGM and FGM. And here you see a sensor reading from a young woman. She actually has a high normal A1C, and the green arrows means she's eating something. So she's always eating. And the purple line is a glucose curve, and we see there's nothing. Now there's a flat curve. Today we know this person is very insulin sensitive, has a very low diabetes risk, maybe need only 1% of the insulin the pancreas can produce to regulate blood sugar. But here is her father. It's also truly her father. He has actually a better A1C than the daughter, but immediately you see there's a different curve. There are fluctuations before he wakes up. This is maybe breakfast, lunch, then there's glucose going down. There was no physical activity, no medication. The difference to the father is very insulin resistant. He needs about 80% of the insulin the pancreas can produce to regulate blood sugar. And this is a big difference between daughter and father. The father maybe has another 2 or 3 years until he develops hyperglycemia and another 10 to 15 years until diabetes is diagnosed. So, but this would be the right person to start preventive measure. This would be the right person to change something in lifestyle, to add an intervention, because here we truly can prevent diabetes from developing. The problem is we don't find them. They are not coming to us. We cannot give a sensor to everyone, at least not yet. And so we have to think about different approaches. But the logic behind is, if we know that this fluctuation of glucose become more and more important, and this is the case, the treatment goal or the preventive goal would be to do whatever we can to cut fluctuations in the high range and fluctuations in the low range. And by this, reducing the amplitude of glucose fluctuations, and by this preventing diabetes, or also in the case the patient has diabetes, improving the outcome. So if you have two people and both have an A1C of 7, one has a low fluctuation, the other one has big fluctuation, the one with a big fluctuation will die because of a stroke or a heart attack. The one with a low fluctuation maybe even don't need an additional treatment. Diabetes is a disease with a dysglycemic continuum. On one side, this is bad for the development of the diabetes. On the other side, it's good for the prevention of diabetes, because the dysglycemic continuum means any increase in glucose goes along with a worsening of the outcome of the patient, but vice versa, any improvement of glucose is improving the outcome of the patient. And here you see the different stages of diagnosing prediabetes or diabetes. It's related to the glucose level and hyperglycemia. But if you imagine that this scale is about a lifespan of a patient, in the beginning, insulin, glucose, and proinsulin, and also free fatty acids are very normal. And then free fatty acids are increasing. They are deriving from the visceral fat. So they trigger the development of insulin resistance. That's why insulin levels are increasing, and later on proinsulin levels are increasing. And this is the clinical dilemma we have to address in diabetes care. Why is the visceral fat so dangerous? Because today we know more than 730 peptide hormones are released out of the visceral fat, and they make our patients getting diabetes. They make our patient getting sick, getting dementia, basically they are related to any chronic disease. They are releasing also free fatty acids. And those are making the insulin resistant. And today we have a new player on the game. It's the hepatic fat. And around the time where pro-insulin increases, many of the patients also accumulate hepatic fat. The hepatic fat is a booster in the development of diabetes. So you can imagine if you have 100 grams of fat in the liver, the development of diabetes is 3 times faster than without the hepatic fat. And the bad part of the hepatic fat is that hepatic fat is making you becoming a non-responder for physical activity. Here diabetes starts, here we diagnose diabetes. So we are coming far too late because the pathophysiology of the disease is here. We have to think about how can we address the people in this clinical paradigm to act early to prevent diabetes from developing. And as I just told you, the interplay between visceral fat and hepatic fat, this is what makes the people getting diabetes. And here you see 2 examples. This is subcutaneous obesity. It may not look good, but this is a patient from myself, and he has a perfect insulin sensitivity, but a lot of subcutaneous fat. This one is in danger because this is the visceral fat depot, and this is producing all these hormones, making us sick. And we could say the visceral fat is making us sick, the liver fat basically kills us. So we have to remove both of the fats. And the question is, how can we remove this? Firstly, here is shown that insulin docks to the receptor, all the substances are switched on and phosphorylated, and then the GLUT4 receptor is translocated to the cell membrane and is organizing the influx of glucose. All the red substances come out of the visceral fat and they block this process. And this explains insulin resistance. And this is a common soil for diabetes, metabolic syndrome, but also diseases like psoriasis, dementia, depression, and liver fat makes you becoming a non-responder for lifestyle change and physical activity. So the question is, how can we get these fat compartments away? Visceral fat only can be reduced by physical activity. Hepatic fat only can be removed by fasting. If you fast for 2 weeks without eating any calorie, without eating anything except for water or tea, so it's a kind of water diet, we could say, then you can be sure that you remove about all the liver fat. The liver fat is totally disappearing if you had less than 150 grams of fat in the liver. And this is a very common situation associated with our lifestyle. And I apologize for the German slide, but this is very interestingly shown. If you compare people who have no liver fat to people who have liver fat and then divide them in non-obese and obese, then you see that an obese person without liver fat has, and here is shown the insulin sensitivity. So the obese person without liver fat has a better insulin sensitivity than the obese person or the non-obese person with liver fat. That means obesity without liver fat is less harmful than being slim but having liver fat. And so this is something we have to have in mind, because if we have to decide what is more important for prevention, is it the reduction of visceral fat or the reduction of liver fat? In the moment, I clearly would say making the liver fat disappearing is such a fast and enormous gain of health that maybe this becomes more important in prevention of diabetes. The second step then is the visceral fat. And making the liver fat disappearing can lead to a remission of diabetes. And this, in my eyes, would be the true prevention. Because having liver fat and pancreatic fat and both go hand in hand, they destroy better cell function. Removing liver fat, removing pancreatic fat restores better cell function, and this could be the remission of diabetes. Prevention is effective. This is shown by several studies internationally. Here are studies showing testing prevention of diabetes with lifestyle intervention. And in the green egg, you see how effective lifestyle intervention is. It's 67% of diabetes can be prevented, but also drugs have a potential. The difference between lifestyle intervention and drugs is if you stop the drug, the effect is gone. If you stop lifestyle intervention, the effect is still sustainable for, we tested in studies 20 years later. So if you had a 4 years lifestyle intervention, 20 years after the lifestyle intervention, the effect is still measurable, and a good effect is still measurable. So it's a kind of legacy effect that the body remembers any period of good lifestyle and healthy lifestyle. These are the goals for prevention of diabetes: body weight reduction, less fat, less saturated fat, a lot of fibers, so about 30 grams of fibers per day, and physical activity. And it doesn't mean 150 minutes physical activity per week. It means 150 minutes extra physical activity per week. And this can be translated to about 10,000 steps every day per week. If we take these 5 goals I just have shown you, and we take 100 people who have prediabetes, and none of this lifestyle goal is implemented, 8 out of 100 develop diabetes per year. If you implement all 5, none contract diabetes. So this is 100% promise, we could say, that lifestyle intervention works in preventing diabetes. And if you look at all these studies and go back to the pathophysiology, what they have achieved, the big American and European studies have lowered visceral obesity, have lowered insulin resistance, and lowered high normal blood glucose. The Asian studies had a wider range, but pathophysiological, they did exactly the same. So on the physiological level, tackling insulin resistance, tackling liver fat and visceral fat, these are the goals for prevention of diabetes. But we also have to understand the patient, how the risk develops. And on this slide, you find 380,000 patient years. And it's analyzing if you drink 1 soft drink per day for 1 year, what it does with diabetes risk. If you drink water, it does not increase diabetes risk. If you drink any other soft drinks, it's 40% like a Coke, but the Diet Coke or Coke Zero is increasing diabetes risk per year by 60%. How can this be? And the answer are artificially sweetened drinks. Artificial sweetener, there are 38 artificial sweetener available in Europe. 36 do what I want to tell you. They change the microbiome. They change the bacteria in our gut. There are 14 other bacteria strains invading our gut. They still help us to digest. They are not painful. But what they do is this bacteria produce fatty acids. They produce fatty acids, and their metabolites are incorporated through our gut in the bloodstream, like if we would eat a tiramisu. And if you are physical active, this change of gut microbiome with the bacteria producing these fatty acids, if they are incorporated into our bloodstream, they land in the liver and they make a gain of liver fat. And by this, they make the patient or yourself becoming non-responder to physical activity. And this is a disaster, because if you have visceral fat, you have a high disease risk, high diabetes risk. So physical activity is the way to reduce visceral fat amount. But if you also have liver fat, the effect of physical activity is diminished. So you walk 10,000 steps and it works like 2,000 steps only. So then a devil's cycle starts, finally leading the person getting diabetes. But if we now think about changing lifestyle, it's also not so easy, because if our patient has an infection or cancer, they normally trust us what we recommend them. If we talk about diabetes and obesity, we as physicians or diabetes teams are out of the game to decide about patient lifestyle, because others are more relevant, and this is a peer group of the patient. So the family, friends, colleagues at work of the patient are more important for their lifestyle, and the only trigger to change lifestyle is quality of life. So if we and also our patient want to change lifestyle, they want to see that the quality of life improves within 2 days. Otherwise, they will not adhere to a change in lifestyle. And this is a challenge. But this is a challenge we have to tackle if we talk about prevention of diabetes. But it works. This is shown here by a behavior change model. There's a theory, and here are the techniques you can use to help the patient to go through these stages. Patients who are not motivated, first, the patients themselves in the peer group with our support have built a motivation, then develop an action plan, and then maintaining to put this action plan into place. Techniques like motivational interviewing, reflective listening, change talk can help us in communicating with the patient to move the patient through the stages. This is something what I strongly recommend you to learn. It takes minutes to learn, seconds to apply, and it saves you actually a lot of time in talking to the patient, and it helps to implement preventive measures. What are standards in diabetes prevention? We had the chance to have a large European project with colleagues from Romania, and we developed a guideline and a toolkit for diabetes prevention, which is currently implemented in 57 countries worldwide. We developed an educational program for prevention manager. So the workforce for delivering diabetes prevention in Portugal, for example, all diabetes educators are prevention managers. So they do both diabetes education and prevention programs. The toolkit is a cookbook for diabetes prevention. Could be on your desk. Everything is written in what you have to do for diabetes prevention. And it's not tackling or targeting only physicians, also politicians and policymakers, because developing policy is the same as important. And the toolkit answers all important questions for building up your own diabetes prevention program. And it finishes with a positive message: do it. And it's sometimes much more important to start doing it than to do everything correctly, because if you don't do anything, you cannot prevent. So starting in your environment with preventive programs, with preventive measures, with preventive intervention is very important. And if you are interested, the intervention or the training program for becoming a prevention manager is an 8 days program where those people learn the techniques and the evidence and the interventions for diabetes prevention. This is freely available for everyone in Europe. The next question is how to apply this in your environment. Here is an example for a structured intervention program for diabetes prevention. It's an occupational health sector. And based on the risk, so first we measure the risk, then intervention to physical activity starts, and then based on how high the risk is, the intensity of the intervention changes. And those programs are available in many languages, also in Europe. Finally, I already mentioned fasting, and what we have learned actually in the last 4 years, I would say, is that fasting is probably the fastest gain of health you can generate, and it's also the biggest gain of health you can generate for an individual. Why is it like this? The only way to remove liver fat is fasting. There's no drug available. There are drugs associated with a little bit diminishing liver fat, but there's no drug available to make the liver fat disappearing. There's no lifestyle associated to make liver fat disappear except for fasting. And fasting in this case for me means for 2 weeks, 14 days, not to eat any calorie. And how does it look like? Or how can you do it? What to recommend to the patient? Fasting is not only something for patients, it's also for people with pre-diabetes, for people who have a diabetes risk who would benefit from it. You start by stopping eating. You have to empty your intestine. You can take globosalt or enema globosalt at the beginning. And I would recommend to have a glycera or enema every second day to keep the gut empty. The strength is if the gut is empty, it's not moving anymore, and appetite and hunger is disappearing. You have to drink a lot of water because you have to push the kidney to excrete all the toxins mobilized by the fasting. The first and second day, you still have appetite and hunger. Then the third and fourth day starts becoming catastrophic, like a big hangover that you feel like. And what happens on on the third and fourth day? Your body switches from burning glucose to burning ketone bodies. And if you have the same amount of glucose in ketone bodies, the ketone bodies contain 80% more energy. So it's a superpower, super fuel for our body, especially for the brain and the heart. And ketone bodies are brilliant. And but they are not available. So the body has to mobilize the ketone bodies. And where are they coming from? From the fat. So if you fast after the third and fourth day, the body starts breaking down fat to generate ketone bodies and then to burn these ketone bodies. And this takes energy to make energy, and that's why you lose a lot of weight. In these 2 weeks, you can lose about 10 to 12 kilograms of body weight. And the ketone bodies is like cocaine for the brain. And so on the fifth day, most of the people fasting, they are in a kind of fasting high. Feel good, feel strong, sleep only 4 to 5 hours a night, but still feel energetic. And they break down every minute fat. And what is the easiest fat to tackle if you switch to ketosis? It's the liver fat. So firstly, the liver fat is mobilized, then the visceral fat is mobilized. So you lose or you basically tackle the roots of prediabetes and diabetes. But if you lay in bed for fasting, muscle is broken down, but a muscle who is used is not broken down. So you have to walk 10,000 steps every day if you are fasting. It's the same as important how to stop fasting, because this will define about the benefit of fasting. The first day for the fasting break, you can eat 600 kilocalories, and then 800, 1000, 1000. After the fifth day, you can have your normal meals again. For these days, you have to drink still a lot of water and celebrate if you have achieved the 2 weeks of fasting. And here's an example of a fasting AGP of someone who has diabetes. And this is the corridor where the glucose should be in. And you see, due to the fasting, you have to generate a flat curve of glucose. And this looks like the curve of the lady I showed you at the beginning of the talk, flat insulin sensitive glucose curve. So finally, what you can achieve with the fasting is this. You have an enormous breakdown of liver fat up to 0, and you improve the total physiology of diabetes development. And this will not be forgotten by the body. So for the next 2 to 3 years, you have generated an enormous benefit for the patient. At the end, prevention has to address needs of the patient. You cannot be able to develop a prevention program against the need or against the wish of the patient. And it could be like developing assessments for the patient and using the assessments in combination with digital tools and combining both and call it risk stratification, and then have 100 different interventions available. And assessing this information by using digital tools can tell you what kind of intervention will be the best for this individual patient. And this will tell us that smart health will change our life in diabetes prevention. Here you see how oral antidiabetics lower glucose, how lifestyle is doing this, and here how digital tools are doing this. And here the last column are young digital tools, so smartphone-based apps. And you see there's a big lowering of A1C. How can this be that a smartphone-based app lowers A1C? And I apologize for switching. The answer is very easy. We are in the pocket of our patient. We never have been so close to our patients than being in the pocket. And in my eyes, digitalization in diabetes care will change our way to do diabetology, but it is a brilliant opportunity to become close to the patient, to apply interventions, and it's a brilliant opportunity for prevention. Here you see examples of digital applications for diabetes care and diabetes prevention, or digiceuticals, or digital therapeutics, licensed already in Germany, and reimbursed of the health insurance in Germany, doing diabetes prevention for our patient. This is enough. Don't forget the 10,000 steps, because this is the evidence for diabetes prevention. The classical pedometer we have used in the past, if the patient was using a pedometer and was looking 3 times a day on the step count, he was walking the end of the month 3,000 steps more than the beginning of the month. But don't trust your physician. Here are 31 German diabetologists on this picture. Only one is on the stairs. All the others are using the escalator. Here's the airport in Doha, the airport in Munich, and the airport in Dammam in Saudi Arabia at diabetes meeting. And think about being a good example for your patient, because the patient is trusting you, and being a good example is a very motivational aspect. Don't forget the 10,000, and let's work together with all our ideas, all our potential, and all our vision and mission to finally walk away from diabetes. I thank you a lot for your attention, and I apologize for not being present to answer questions, but I would love to come in the future to discuss this personally with you. Thank you very much.